Guy Mintz. I'm the president of Northeast Lipid Association. I want to welcome everyone to our inaugural Neela Nights program. And I came up with the idea of Neela Nights to promote education for all of us throughout the year, to encourage camaraderie and foster relationships within our Neela chapter, and have the opportunity to have some of the national leaders in the area of prevention and lipidology address us throughout the year. So before I introduce our speaker, I just want to let you know that you can put questions in the chat box and we'll try to get to them at the end of Dr. Brown's presentation. So it's a great honor and privilege for me to introduce Dr. Alan Brown, who I consider a mentor and a friend. He is an interventional cardiologist that saw the better ways and became a preventive cardiologist. He's an associate professor of medicine at the cardiology at Loyola Stritch School of Medicine in Illinois. He is the director of the Division of Cardiology at Advocate Lutheran General Hospital in Park Ridge, Illinois, and co-director of the Cardiology Service Line. He has served as chairman of the Board of Governors for the American College of Cardiology. He has been very active within the American College of Cardiology, serving on the Prevention of Cardiovascular Disease Committee, Scientific Program Committee. He's also served as member of the ACC Board of Trustees. He's also former president of the National Lipid Association and a master of the National Lipid Association. Dr. Brown has authored numerous articles and chapters in books. He's also the host of Lipid Insights and Heart Matters, internet radio shows such as ReachMD. He is a true professor and a friend, and I am happy that he represents our first speaker in our inaugural Neela Nights program. So without further ado, I give you Dr. Alan Brown for a tour of lipid disorders from basics to disease. And with that title, this talk can go anywhere. So maybe a double scotch is in order. So with that, Dr. Brown, take it away.
Yeah, thanks, Guy. Thank you. It's an honor to be able to speak to you guys. Obviously, you're all my friends and colleagues, and a lot of this is probably going to be a review for you. And I told Guy, I could do 3 hours on this, just on metabolism and on lipid disorders, and I don't want to torture you. So I'm going to abbreviate some of the information. But since you're all lipid geeks, first of all, my mother wrote that introduction. So Guy, thank you for reading it. I appreciate it. She was very thorough. But second of all, I want to share with you kind of over the years, as I was trying to understand lipids and metabolism, as well as genetic disorders, just the way I've thrown it together to try and explain it. And I've used this in the master's course to try and give some understanding. And I'm going to try to skip some things because I know that you guys know it. But what I'd like to do is try and finish in enough time that if you have any questions about any specific topics that we talk about, we'll do it. I mean, it's hard to do all of lipidology in an hour. And like I said, I don't want to drive you crazy. If questions come up during the talk, it's a relatively small group, so I am more than happy to take questions. And since they're, it's, as I said, relatively small group, I'm okay with verbal questions if you like. So let me start with this so you guys can see my screen. So just a comment about the NLA, and that is that there are very few organizations that actually have a curriculum that they think everybody in the specialty should know and write it down. And when we put together our coursework for master's course and board review and whatnot, we had to follow the core curriculum. And I know that they do the same thing with the board exam. So I wish every organization did that. They define what you need to know. They make sure that the speakers address all those issues and that the board exam reflects the knowledge base that we're supposed to know. And that's something that I've always been proud of with regard to the NLA. But I'm not going to go through all of these things, so you can relax. So what are we going to do today? I'm going to start with just things that you know, the basic structure of lipoproteins and why we have them, and a brief overview of metabolism, and then we can quickly hone down on some of the different steps. And we'll end with the many ways we can get screwed, which lead to genetic disorders. And I think, as you guys all know, the more we do genetic testing, the more we realize that things aren't quite as simple as we thought they were. So there's a lot of complexities and a lot of intermediate syndromes that are related to multiple SNPs and not the large gene mutations that I'm going to talk about today. But this is the classical knowledge. So obviously, fats don't circulate in water. And so humans have a very interesting way of dealing with that, which is to have this outer polar surface coat, what I call the spaceship that carries the lipids. And as you know, it's water soluble on the outside, fat soluble on the inside. And then all the lipoproteins have varying amounts of cholesterol, ester, and triglycerides in their core. And in fact, the ratio of triglycerides to cholesterol in that core gives us, number one, an idea of what that lipid particle is. And number two, helps us when we look at the lipid profile to try and determine what disorder the patient might have. It's not perfect, but it's a clinically useful tool, and we'll talk about that. And then on the surface, as you know, there's the apoproteins, which are the tattoos of the lipid particle that tell you where it was born, with the ApoB100 being from the liver and ApoB48 from the gut. And they also, the apoproteins also determine, they turn on and turn off metabolic pathways that are necessary for the metabolism of the particle. And it, obviously, they also bind to the final receptor where those lipid particles are taken back up by the liver. So this is a little more stylized Scott-Grundy picture, which shows the surface coat with the phospholipids in it that are polar on the outside and non-polar inside, and then the triglycerides and cholesterol within it, and the apoprotein stuck on the surface. This is in every lipid talk. I hate this slide, just to show the variable size of lipid particles. And traditionally, we thought that the HDL and the chylomicrons were not participating in atherosclerosis. So as you all know, we've learned that that's not totally true. About 15% of patients with chylomicronemia can show up with atherosclerosis. And it may be that they don't have the classic chylomicronemia syndrome. That's a discussion we can have a little later. And we know that HDL can be proatherogenic in certain situations. But traditionally, from VLDL down to LDL and Lp(a), those are considered to be the atherogenic particles, as you all know. Now I'm going to give you a minute to copy this slide. Just kidding. We'll talk about the different apoproteins, what particles they're located on, and it'll be easier as we go through what I call the solar system. But I have provided these slides when I give this talk for people who are studying for their boards. And this is one way to look at it, to look at the different lipoproteins and what apoproteins are on them. And the other way to look at it is the apoproteins themselves, where they're located and what their functions are. So that's not for today's discussion. I do remind all of us, including myself frequently, that not everybody who has dyslipidemia has a genetic disorder. I saw somebody last week who was referred to me for cholesterol of 700. And I thought this should be a homozygote, but it was an adult Chinese man who had no evidence of atherosclerosis. And he didn't remember being told as a child that he had high cholesterol. And as I looked through his chart, I realized that he was recently admitted with ascites and nephrotic syndrome. And he was sent to me for dyslipidemia, and I sent him back to renal to take care of the nephrotic syndrome. But it was pretty shocking. So don't forget, there are a lot of secondary causes of dyslipidemia, also a little bit out of scope for today if we want to get through things. So here's my solar system. I always say we're going to look at the solar system first, then we'll land on each planet and learn a little bit more about what's happening in the different steps. So as you all know, there's two ways that lipids will enter the bloodstream. One is from the diet, the so-called exogenous pathway, and the other is what we make within our body, primarily from the liver and a little bit from the intestine, and that's the endogenous pathway. So let's talk about that real quick. And I guess I always start with, why the heck do we have lipid particles? And is there any common theme that makes some sense out of all these different particles and all of the noise when we talk about them. And it's pretty simple. We make particles that are rich in triglycerides, and those triglycerides are removed as the particles go through the circulation and broken down to fatty acids for energy. And what's left is the waste product, which is primarily cholesterol. So if you think of whether it comes from the diet or it comes from the liver, as the new particles are entering the circulation, they are very triglyceride rich. And then as those triglycerides get burned out of those particles, removed, converted into energy, you're left with particles with much less triglyceride and relatively more cholesterol. The cholesterol is inert. It's not coming out of those particles, just the triglycerides. So with that said, if we start with the exogenous pathway, when we eat a Whopper, right, what happens? That dietary fat goes into the intestine. And in the intestine, with the help of bile acids and pancreatic lipase and the appropriate absorption protein, NPC1L1, we absorb triglycerides and cholesterol into the intestinal mucosal cell. And then the mucosal cell packages the first lipid particle that's going to be provided to the circulation, which is a very triglyceride-rich particle, very high in energy, the chylomicron. It's called the chylomicron because it's chylous. It goes into, it actually gets picked up by the lymphatics around the gut. It doesn't go directly in the circulation and then dumps into the circulation via the thoracic duct. So it's important to remember when we get into the genetic disorders that there's about 10 triglycerides to every cholesterol in the chylomicron. So if someone has pure chylomicronemia, their ratio of triglyceride to cholesterol in their lipid profile is 10 to 1. And there's nothing else with that higher ratio of triglycerides to cholesterol. So if you see 10 to 1, triglycerides of 4,000, cholesterol 400, you can pretty much take to the bank that that person has primarily chylomicrons. So that's just one of those helpful things to remember. And then through the action of lipoprotein lipase, which is, as you know, ubiquitous in the capillaries throughout the body, the lipoprotein lipase removes triglycerides from the chylomicron and breaks them down into free fatty acids. Then what's left is a smaller particle with relatively less triglycerides, a chylomicron remnant, which is picked up by the liver via a remnant receptor. So that's pretty simple. Big particle with triglycerides in it, burn the triglycerides off for energy through the actions of lipoprotein lipase, and then that particle is removed. And you probably all know that ApoC2 is required to activate lipoprotein lipase. There's 5 different proteins that are required for lipoprotein lipase to work properly. And we'll talk about that in a little more depth. So that's how dietary fat is handled. Now, what happens on the endogenous pathway? The liver makes a particle that's analogous to a chylomicron. It's large, it's full of triglycerides. The ratio isn't quite as high as a chylomicron, it's 5 to 1. And if you look at a lipid profile in somebody with hypertriglyceridemia, and the triglycerides are exactly 5 times the cholesterol, you want to think VLDL. Not perfect, but it helps you sort out the different genetic disorders that we're going to talk about. And the same action occurs where the VLDL gets acted upon by lipoprotein lipase. The triglycerides are removed. There's also an interaction with HDL, which we'll talk about in a minute. And that particle becomes a smaller particle with less triglycerides, or a so-called intermediate density lipoprotein. The other name for that is a VLDL remnant for obvious reasons. The ratio of triglyceride to cholesterol in a remnant particle is 1 to 1. So hence those lipid disorders that are characterized by high levels of intermediate density lipoprotein have equal cholesterol to triglycerides on their lipid profile. And that's what you see with type 3 dyslipidemia. That should be a clue right away. If you have a 300 cholesterol and 300 triglycerides, that type 3 is a possibility. Again, these aren't hard and fast rules, but they help. They help in understanding what's going on. And then if either these intermediate density lipoproteins get acted on by more lipoprotein lipase and the triglycerides are removed until they're all gone, and what would you get then? You get an LDL, that's 99% cholesterol, no more triglycerides. But more commonly, the intermediate density lipoprotein can go back to the liver via what we call a shunt pathway. obviously that LDL cholesterol gets picked up by LDL receptor, as you know. The shunt pathway is very interesting, and that is that these intermediate density lipoproteins can go back to the liver and bind to a receptor via ApoE instead of ApoB100, which binds to the LDL receptor. You might think, well, so what? Well, when ApoE binds, the particle sits on the receptor for a fairly long time, and right next to the receptor is hepatic triglyceride lipase, which is on the surface of the liver, or hepatic lipase, as it's sometimes called. And then the triglycerides get removed on the surface, and that protein can either be pulled into the liver as a way to recapture cholesterol, or it can be released into the circulation as LDL. So instead of lipoprotein lipase out in the capillaries removing the final triglycerides, these particles can go back to the liver as intermediate density lipoproteins and be metabolized by triglyceride lipase on the liver, hepatic lipase. So why is that important? Well, it turns out actually in most people, probably the majority, go back through that shunt pathway and not directly to LDL. Some of that is genetic, but if you have a mutation in ApoE where the intermediate density lipoprotein doesn't bind rapidly but sits on that ApoE receptor for a long time, that's actually okay. I don't know if you guys realize this, but if you have ApoE2E2, right, which we think causes type 3 dyslipidemia, that by itself doesn't cause any problem, because as that particle sits on the receptor for a long time, the hepatic lipase metabolizes it very completely, and those patients actually have a less risk for atherosclerosis. So what you need to have type 3 is a mutation in ApoE, so you have slow binding, but you also have to have overproduction, whether that's due to diabetes, obesity, alcoholism, something that overproduces the VLDL, so that not only do you have slow clearance, but you got overproduction and you get a logjam and too many intermediate density lipoproteins. We'll talk a little bit more about that in a minute. Any questions on exogenous and endogenous metabolism? And I made these slides years ago when Mike Davidson and I used to give these talks, and we had actual physical slides, and we had to figure out a way to do PowerPoint, and so we came up with this. So I hope it makes sense. All right, so again, we can land on each of these different areas and look a little closer. I'm not going to do that because I want to get to the genetic disorders, and we only have about 35 minutes left, but we can talk it through real quick. So you guys know that cholesterol gets into the intestinal mucosal cell via MPC 101, right? And that's what ezetimibe blocks. The MPC 101 will bring in sterols, whether it be animal sterols like cholesterol or plant sterols, into the intestinal cell. And plant sterols are toxic, so they get secreted back into the stool by a second protein, which I call the sump pump of the intestinal mucosal cell, the ABCG5G8. And that's how we avoid absorbing plant sterols and only absorb cholesterol. But triglycerides come in a completely different way. They don't come in through that sterol protein, transport protein. That's where the pancreatic lipase works. So triglycerides are in fat in the gut. Pancreatic lipase cannot work on fat. It needs a water-soluble surface. So your bile acids help to be a surfactant, which allows the pancreatic lipase to act on the fat and break down the triglycerides. Pancreatic lipase breaks triglycerides down into a monoglyceride and 2 free fatty acids, which is weird. I have no idea why that is. You know, lipoprotein lipase removes all 3 fatty acids from a triglyceride. So you have a glycerol and the 3 fatty acids. But pancreatic lipase, for some reason, takes only 2 of the fatty acids off. You're left with a monoglyceride. And amazingly, that can be absorbed into the mucosal cell. And then the cholesterol comes in through that NPC 101, and then they're repackaged within the intestinal mucosal cell into cholesterol, triglycerides, and finally into a chylomicron. The Next step is the lipoprotein lipase step. And I just want to take 1 second and talk about that. This, by the way, is one of my patients who had a mutation not in NPC 101, which would be genetic Zetia. He had a mutation in his ABCG5G8, and he could not dump his plant sterols. So he absorbed the plant sterols. He got these tendon xanthomas, and one of the clues was his lipids weren't very high. Sent to me as a thought to be a familial hypercholesterolemia, but his total cholesterol was only 240. And when we did phytosterols in the blood, it was markedly elevated. And the treatment for that is ezetimibe, because it blocks not only cholesterol absorption, but all sterol absorption. And there's premature atherosclerosis associated with this. And he was the only living sibling. His sister and brother were already dead of cardiovascular disease, and he had had a bypass surgery. But just an interesting case. I'm going to skip the stuff that we won't have time to go into depth with, but maybe next time. Okay, so just a quick comment about lipoprotein lipase and how it works. And it's important to know that lipoprotein lipase is actually manufactured in fat and muscle cells. It gets secreted out into the interstitium, in between cells. It's not in the capillaries at all when it's made. So somehow it has to get from the interstitial space into the inside of the capillary so it can act on triglyceride-rich particles. So the first step is the lipoprotein lipase gene has to be correct to make the lipoprotein lipase. Then there's a maturation factor called lipase maturation factor 1, or LMF1, that matures it and moves it out of the fat or muscle cell into the interstitium. And then there's a protein, which I call the long arm of the space shuttle. You remember that arm that came out and grabbed things? It's called GPI-HBP1, that actually grabs the lipoprotein lipase from the interstitial space and swings it into the capillary lumen. And then, as you know, ApoC2 and ApoA5 are required for all of the breakdown of triglycerides. So here's just a diagram of that. You can see the myocytes and adipocytes on the bottom where the lipoprotein lipase is down there. The GPI-HBP1 in that orange lumen of the capillary, but it has swung down and picked up the lipoprotein lipase, which is shown here in red. And then on the chylomicron, there's that yellow ApoC2, which is required to turn on the lipoprotein lipase. So we now have 4 things that have to work right. We got to have a lipoprotein lipase gene that works right. There has to be an appropriate LMF1 to move that lipoprotein lipase into the interstitial space and mature it. Then we have to have that GPI-HBP1 to pick up the lipoprotein lipase from the interstitium and swing it up into the capillary lumen. And we need ApoC2 to activate the lipoprotein lipase. And I'll show you, this is just a drawing of the GPI-HBP1 picking up the lipoprotein lipase and swinging it into the lumen. And here's where ApoA5 comes in. It's like a fork. Here it shows it delivering it from HDL. But if you think about it, it just holds everything in the right configuration. So in the middle of the picture, you see the VLDL with the A5 in red binding the lipoprotein lipase. And all of that holds everything in the right configuration that the triglycerides can be broken down. So 5 ways to get screwed for chylomicronemia. Lipoprotein lipase gene itself, LMF1, the GPI-HBP1 protein, ApoC2 or ApoA5 mutations. Any of those mutations can lead to chylomicronemia syndrome. And I'm going to, as you know, VLDL is produced in the liver, and you guys are all experts on LDL receptors. I just want to take a second and talk about HDL. So HDL, as you know, is like psychiatry. Half of what we know is correct, and nobody's sure which half. And the more we think we know about it, the more we realize that, you know, maybe it had nothing to do with atherosclerosis. In ancient humans, we didn't live long enough to get atherosclerosis, and it's probably more related to wound healing and other things than acute injury than anti-atherosclerotic. But we know that it is involved in reverse cholesterol transport. So the HDL, we haven't talked about much in this diagram. HDL has really three functions. It can be the garbage boy, can go out to the peripheral tissues and pick up cholesterol. And the way it does that is when it sees a macrophage loaded with cholesterol, it has ApoA, capital A1 on its surface that turns on that ABCA1 transporter protein, which moves free cholesterol out into the circulation. And then free cholesterol is not fat soluble, so it has to become a cholesterol ester to go into that happy fat soluble core. So LCAT, or less than cholesterol acyltransferase, adds an ester to the free cholesterol, and then it goes into the core of the HDL, taking an empty pita pocket and making it a juicy gyro full of cholesterol. And then, as you know, it's that can be picked up by the SRB1 receptor on the liver. So the first thing HDL does is it's a garbage collector. The second thing it does is it's a delivery boy. It turns out that cholesterol for the testes, ovaries, and adrenal glands to make steroid hormones comes from HDL. HDL delivers the cholesterol to those tissues. So people were always worried if we lower LDL too much, somehow we're going to affect testosterone, estrogen, and maybe adrenal hormones. But LDL is not necessary for that. HDL delivers cholesterol. And then the third piece is that it can hand off cholesterol. So if you think of an empty toilet paper roll, and you could connect a particle loaded with triglycerides like a VLDL with an LDL or with an HDL. HDL has only cholesterol in it. VLDL has a lot of triglycerides. So if you could put an empty toilet paper roll between the two just by concentration gradient, triglycerides are going to move into the HDL and cholesterol is going to move the other way. And that's actually how HDL interacts with VLDL to make smaller VLDL remnants. It delivers cholesterol to the VLDL, but removes triglycerides. So you get the smaller remnant particle. So in addition to lipoprotein lipase, there's transfer of triglycerides via this empty toilet paper roll to virtually all other particles. And that empty toilet paper roll is CETP, cholesterol ester transfer protein. And you can transfer triglycerides from VLDL into HDL, from LDL to VLDL. So any particles, the triglycerides can move back and forth. What's the implication of that? If there's triglycerides in the particle, it can be burnt. It can be metabolized into a smaller particle. So if you've ever wondered, why do people with high triglycerides tend to have low HDL? It's because their CETP, empty toilet paper roll, connects the VLDL to HDL. People with high triglycerides usually have too much VLDL. The triglycerides fill half the HDL, and then when that HDL comes up to the hepatic lipase on the liver, or endothelial lipase in the circulation, you remove the triglycerides and you're left with a small HDL, which goes out in the urine. So high triglycerides means you got too many triglyceride-rich particles. You start transferring that into HDL. The HDL gets metabolized into small particles and goes out into the urine. And it's the same reason you get small, dense LDL, because you can transfer triglycerides from VLDL to LDL via CETP. And now an LDL, which should be all cholesterol, has a bunch of triglycerides in it. And as that gets metabolized by lipases, you end up with many small, dense particles. So that's how CETP works. It's actually an empty toilet paper roll. Some people think it's more like a shuttle bus. Doesn't matter. The concept is the same. So this is HDL. So here's an HDL that's coming out, and it comes in contact with a macrophage, and the ApoA1 on the surface turns on the ABCA1 protein, which pumps cholesterol out of that macrophage and into the empty HDL, making a mature HDL. And then that HDL can be goes back to the liver where it can deliver its cholesterol. But if it comes in contact with a triglyceride-rich particle, for example, a VLDL, and there's CETP activation, which happens when your triglycerides are elevated, that empty toilet paper roll can connect the two particles and facilitate triglycerides flowing into the HDL and cholesterol going the other way. And then, as I mentioned, the HDL particle carrying cholesterol can deliver that cholesterol via its apoproteins on the surface, either back to the liver via the SRB1 receptor here, shown here, or it can also deliver it to the steroidogenic tissues via a different receptor, providing cholesterol for making steroid hormones. And we're all familiar with LDL receptors and PCSK9, so I'm not going to drive you crazy with that. Are we ready to talk about genetic disorders? Is that a yes, Guy?
That's a yes, Alan. Keep rolling.
Okay. So let's talk about genetic disorders, then. I'm not going to bore you with what I hope everybody's aware of, which is LDL receptor activity. So I break these down into baskets that make them a little easier to remember. Those disorders that only affect LDL, those disorders that affect triglycerides, low HDL disorders, and something we don't talk about very much, low LDL disorders. And we might not have a lot of time to talk about Lp(a), but again, I assume that you're fairly well versed in that. So the old Fredrickson-Levy classification really just talked about what particles were there. And so this is considered a classification we don't use very much anymore, except when it's easier to say. So type 3 is easier than saying familial dysbeta lipoproteinemia. So everybody still uses the term type 3. But type 1, 2A, 2B, et cetera, doesn't tell you really what the disorder is. So we have different names for these disorders now that theoretically are supposed to help. And I personally don't think they're any better than the old classification, but we'll go through them. So the genetic disorders we're going to cover are chylomicronemia syndrome, then familial hypercholesterolemia and defective ApoB, which basically look exactly the same, familial combined dyslipidemia, type 3 dysbeta, familial hypertriglyceridemia, and a little bit about hypoalpha and hypobeta lipoproteinemia. We're going to do that all in a very short period of time, about 25 minutes. So I don't need to spend a lot of time on familial hypercholesterolemia with you guys. As you know, it can be heterozygous, which occurs somewhere around 1 in 250 people, or homozygous, which occurs anywhere from 1 in 250,000 to 1 in a million, depending on the population. You understand, I'm sure, that that's a disorder primarily, the vast majority of the time, of a mutation in the LDL receptor gene leading to dysfunctional or partially functioning LDL receptors. It is the most common autosomal dominant inherited metabolic disorder. And it is the least commonly diagnosed. 90% are undiagnosed, which is a problem for all of us. And I know all of us have spent time lecturing on that. Familial defective ApoB100 looks exactly like familial hypercholesterolemia, but instead of an LDL receptor mutation, there's a mutation in the gene for ApoB, which means that instead of having a bad receptor where you can't bind LDL, you have a bad key that doesn't fit in the lock. So the binding moiety on the LDL doesn't bind properly. And more recently, in the last 15 years, we've discovered a PCSK9 gain of function abnormality that's very, very rare, but it causes destruction of LDL receptors and clinically looks exactly like familial hypercholesterolemia. And I mentioned that hereditary cytosterolemia mimics FH only in the physical findings, because you can get these pretty significant xanthomas like in the pictures I showed you, but nothing else looks like it. The lipids can be fairly high, so you could mistake it, but the lipids can also be just slightly above normal. And that's always a clue when you see xanthomata in an otherwise healthy appearing person and their lipids are not very high. You should draw a serum phytosterol level. The physical findings for FH, you're familiar with corneal arcus in a young person, especially under age 45. Obviously, that's not specific. You can see it in older people, but under age 45, you should think FH. Extender tendon xanthomas and Achilles xanthomas. And I teach my residents to feel everybody's ankles. And I'm sure you do too. And we talked about the prevalence. You guys are familiar with that. And you also know that homozygous is quite rare and disastrous. It's when you have two mutant alleles for the LDL receptor, which leads to extremely high cholesterols and usually coronary disease by the age of 10. It is autosomal dominant with complete penetrance, and there is a dosage effect. So if you have a single allele mutation, you get half the LDL elevation that you would if you were homozygous. Just a couple things about FH without going through all of this. One thing that's kind of new information. We used to think that Lp(a) was more common in people with familial hypercholesterolemia. That's probably not true. There was a nice paper in the New England Journal about a year ago that when they actually looked at Lp(a) elevation in people with known heterozygous FH, the incidence was exactly the same as the general population, about 20%. So why did we always feel that was more common? Well, the thought is that actually Lp(a) can be measured like LDL. It's measured as LDL in some patients. And one of the clues are that they don't get a good response to statins with a very high LDL. That should tip you off to check Lp(a), since statins don't lower Lp(a). But so what the thought is that those patients were misdiagnosed as familial hypercholesterolemia. They had Lp(a)s of 600 or 700, and it looked like they had FH based on their lipids, but really they weren't FH. So it's just something to think about when you see a patient that looks like FH. They're not getting your standard response to aggressive lipid lowering, to double check the Lp(a), though I'm sure most of you do that anyway. But I thought that was a fascinating article, and what they evaluated again suggested that the incidence of elevated Lp(a) is about the same in people with FH as it is in the general population. We all know that we should be screening everybody for this, and it's been a hard sell. There's been a resistance to screen children because we don't want to give them a phobia, but unfortunately we're missing those folks. And we generally think that everybody in the population should get an LDL screening by 18 years old. And anyone with parents who have high cholesterol or premature heart disease in the family should be screened at a young age, possibly 2 to 5. And if their LDL is over the 90th percentile, so for a child that would be over 160 LDL, and an adult when we see over 190, it doesn't confirm the diagnosis, but it makes you start to look deeper. And if you have a parent who has heterozygous FH and their young child has an LDL over 160, you can be pretty comfortable they have FH. So you're all, I think, familiar with the treatment, and the only thing to remind everybody, which I tell all of my young women, even if they're 10, is about the pregnancy issue. And that's been muddied a little bit because the FDA kind of removed the category X for statins in pregnancy and said that if the benefit outweighs the risk, that you could consider using a statin, and maybe Prava in the 3rd trimester. You know, what I tell my patients, and if we have time, I'd be interested in what you guys are saying, is that, you know, there are patients who are very, very high risk, might have a high calcium score that you're worried about. But in general, we're still not recommending willy-nilly putting people on statins who are pregnant. And if they're otherwise healthy, we tend to stop the statin 3 to 4 weeks before they attempt to conceive and restart it after they're done nursing. And, you know, if they have coronary disease, that's a whole different ballgame, and we consider doing LDL apheresis during their pregnancy, which I've done on a couple of patients. But I think we just don't want to be too cavalier about putting people on statins when they're pregnant who are otherwise healthy, because it could blow up in our face. And we'll see how the registries look of women who've gotten pregnant on statins. And so far, it doesn't appear like there's a bad problem, but I wouldn't bet my career on that. So in familial hypercholesterolemia, it's either an LDL receptor mutation, an ApoB mutation, or a gain of function PCSK9 mutation. And of course, the net effect is you can't clear LDL, so you have very high LDL in the blood. I'm gonna skip this. Just a comment about autosomal recessive hypercholesterolemia. This is a little bit misunderstood. So if you see those little wrenches in the picture, this is a clathrin-coated pit, and those wrenches are the LDL receptor. And at the base of those wrenches are the little pearl, and that pearl is called the LDL-RAP1 protein. That holds the LDL receptor in the right configuration where it can pick up LDL. So if you have a mutation in that LDL-RAP protein, your LDL receptor is cockeyed, can't bind LDL. That is a recessive trait, so it's extremely rare. But the patients look like they have homozygous FH. They end up with extremely high lipids, very resistant to therapy, because their receptors aren't working, not due to a receptor mutation, but due to an anchoring protein mutation. So two things. Number one, the parents don't have it because it's recessive. So it won't have the classic autosomal dominant pattern. And number two, it looks like homozygous FH and is resistant to therapy. And that's autosomal recessive hypercholesterolemia, extremely rare. I have seen some heterozygotes with LDL-RAP1 that look like they had heterozygous FH, and they have a little better response to therapy. This is a homozygote, different tendon xanthomas. This is a heterozygote with Achilles xanthomas. Usually, as you all know, you can't see that. You have to feel the Achilles or you'll miss the diagnosis. So these are pretty impressive xanthomata. This is a patient I had in clinic with more classic extensor tendon xanthomas, and this is a heterozygote. So I always have everybody make a fist. Corneal arcus, as I mentioned, in a young age is important, and xanthelasma can be there for a number of reasons, including in patients with normal cholesterol. So it's definitely not specific, but it's more common to see them in patients with FH. And these are homozygotes, just a coronary lesion in the left main here in a 12-year-old on this angiogram, and then an ascending aorta narrowing on the right due to aortic atherosclerosis in a young patient with homozygous FH. All right, now the ones that we don't talk about as much, genetic disorders of triglycerides. These are rare, so I'm going to go through them quickly with you, just for the sake of time. We talked a little bit about chylomicronemia. It's a disorder that is characterized by pancreatitis starting at a young age. Anybody eating a little bit of fat will get tremendous hypertriglyceridemia. Their triglycerides are generally 10 times their cholesterol level, 10-to-1 ratio of triglyceride to cholesterol, which should make you think about chylomicronemia. And we mentioned it could be lipoprotein lipase deficiency, ApoC2, ApoA5, LMF1, or GPI HBP1 disorders. As you all know, these patients don't respond well in the classic monogenic chylomicronemia. They don't respond well to therapy. And all of our drugs that lower triglycerides are pretty much ineffective. So since we have the lipoprotein lipase doesn't work, that mechanism doesn't work, we have to reduce chylomicron formation. And the way we do that is a very low fat diet. Does anyone know why you don't get VLDL elevation? So these are patients with a problem with their lipoprotein lipase, which also breaks down VLDL. So why wouldn't you get VLDL elevation in chylomicronemia, just chylomicrons?
Maybe it's
Anybody have any idea?
the hepatic lipase, perhaps.
That's right. Yeah, so chylomicrons don't have good binding to hepatic lipase. In fact, very poor affinity. But VLDL has a much better affinity for hepatic lipase.
Yes.
So you can clear your VLDL, but not your chylomicrons. Okay, absolutely. Eduardo, you are right on target with that.
Thank
I
you.
always wondered about that. Virgil explained it to me. Familial combined is an interesting one. So with chylomicronemia, it's a recessive trait. Parents don't have it. They can have mild hypertriglyceridemia, but they're heterozygotes, and the child gets either compound heterozygote or two alleles for the same protein. What's familial combined? A lot of people don't even think it's a disease. One of the things that helps you in the diagnosis is the ApoB level is higher than the LDL, whether they're on treatment or not. So that tells you there's too many particles. And the net disease is overproduction of ApoB. So whatever bucket of cholesterol you have, if you take 2 ApoBs and put them in there, you're going to get 2 particles. If you put 100 ApoBs in there, you're going to get 100 smaller particles. So you make small VLDL, lots of it, because of the overproduction of ApoB. In some patients, they can't move that VLDL into LDL, so they have high triglycerides and high LDL levels. Some patients can move that all the way to LDL, so all they have is a high LDL. So different family members have different lipid profiles. They can have high LDL, high triglycerides, or both. The clue is that it is a dominant trait, so those family members are usually in the 90th percentile for their lipid levels, and their ApoB is higher than their LDL. And in many cases, those patients have diabetes in the family. It's much greater numbers than diabetic dyslipidemia, but in every other way, it looks very similar. And they have a high risk of atherosclerosis, whereas chylomicronemia, because of the large particles, don't seem to have that great of an increased risk. We're learning now that the non-monogenic chylomicronemias that might have multiple SNPs or other disorders that may not have the classic genetic mutations have more atherosclerosis because they probably have other risk factors for atherosclerosis. Now, what about familial hypertriglyceridemia? This is just like the name says, everybody in the family has high triglycerides, unlike combined, where you can often wonder if they have laboratory error and you see different phenotypes in different family members. Familial hypertriglyceridemia is where you make large VLDL particles, not too many, but large. So there's only a slight increased risk for atherosclerosis. But if you got it from dad, dad has high triglycerides, grandpa has high triglycerides. The ratio is about 5-to-1 triglyceride to cholesterol because it's due to large VLDL particles. And because there aren't too many particles, they're just large, there's a minimal increased risk for coronary disease. So again, you come up with this by looking at the family members. It's an autosomal dominant trait. All the family members have high triglycerides. And instead of premature heart disease in the family with familial hypertriglyceridemia, what you see is more pancreatitis in the family. Again, with 5-to-1 ratio, triglyceride to cholesterol. And then type 3, we talked a little bit about. So type 3, you have ApoE2E2 genotype. So you've got a mutation in ApoE. So they're both alleles are E2E2. That slows the clearance of those remnants. But you also have to have an overproduction syndrome. Whether you have familial combined on top of it, obesity, diabetes, high-fat diet, what happens is you can move those particles into intermediate density lipoproteins, but there's slow clearance by that ApoE receptor, so you have a lot of intermediate density lipoproteins. The clue here is it's the only lipid disorder where the physical findings are on the palms of the hands. So you get orange palmar creases and xanthomas on the palms. Every other lipid disorder is in different places. And the other clue is that these people have roughly equal triglyceride to cholesterol because the intermediate density lipoproteins are 1-to-1 triglyceride to cholesterol. So when you see 400 and 350 cholesterol, you should be thinking of type 3. Also, their ApoB levels are low, whereas these other diseases with increased particle numbers, you have high ApoB levels. Type 3 is characterized by low ApoB levels. So obviously this is the old spin the serum down, leave it in the fridge overnight. And the clear one is normal, the turbid one is VLDL, and the supernatant is chylomicrons. And thank God we don't do this anymore. I always joke that this is Dr. Mike Davidson's rear end, but it isn't. He just gave me this slide. These are tuberoruptive xanthomas, and as I'm sure you all know, they're not specific for any triglyceride disorder, but with high triglycerides, you can get this on the buttock, you can get it on the trunk, and other physical findings of high triglycerides. Again, not specific for the disorder, except for those palmar xanthomas I mentioned in type 3 or orange palmar creases. You can get these pink arteries in the eye, lipemia retinalis, the pink color of the arteries, and that is associated with severe hypertriglyceridemia. So I'm going to go through this quickly and just for the sake of time. We mentioned the 5 gene mutations that cause chylomicronemia syndrome. And if you look on the right, it's interesting to see what the incidence of those different mutations is in people with chylomicrons. We tend to think it could be any of these things because we learn about it in our classes, but 95% of the time it's lipoprotein lipase. C2 and GPI HBP1 would be only about 2%. And LMF1 is the least with 0.4% of chylomicronemia patients. So by far and away, lipoprotein lipase mutations are the most that we see. And again, I'm going through this because I want to respect your time and we're getting close. I just wanted to show you the type 3. One thing we didn't mention about type 3 is it's very diet sensitive. So type 3, what happens is you have to have overproduction of ApoB due to all the reasons we discussed: diabetes, obesity, high fat diet. And because the ApoE2 genotype, you bind slowly. And so the net effect is that you build up a lot of intermediate density lipoprotein in the blood. And this is a picture of the orange palm accretions. And if you biopsy them, you see intermediate density lipoproteins in there. And this is just an example of the xanthomas on the palms, which you only see in type 3. So again, the only disorder with physical findings on the palms. And we're almost out of time. So you guys, on the low HDL syndromes, just think of it in two ways. It's either low because you underproduce HDL, which seems to be a significant risk for atherosclerosis, or it's low because you make plenty of it. It just has a rapid turnover, so the steady state is low. So with ApoA1 Milano, which has generated lots of interest over several decades, you have a mutation where you make plenty of HDL, but it's rapidly metabolized. So the steady state is low, and that HDL is pretty effective, we think, in reverse cholesterol transport. And so even though they have a steady state low HDL level, they have very little atherosclerosis. And we've tried to make artificial ApoA1 Milano for a long time. Then we have familial hypoalpha, where you actually have a mutation in ApoA1, and your HDL is low because you don't make much HDL. And those people actually have very high risk of atherosclerosis, and that's a dominant trait that runs in families. And then the rare Tangier's disease and fisheye disease. How do you remember these? Tangerines are orange. So Tangier's is the orange tonsils when you take your board exam. That's how I remember it. Tangerines are orange. And because they don't have that ABCA1 transport protein, there's a mutation. They can't pump cholesterol out of the tissues and into the circulation for HDL to pick it up. So they get a buildup of cholesterol in their bone marrow and their tonsils, which is why they get the orange tonsils. What do cats eat? They eat fish. That's how I remember LCAT for fisheye disease. But if you don't have the lecithin cholesterol acyltransferase, you can't take free cholesterol that's been pumped out of the foam cell and esterify it. So you can't get it into the core of the HDL. So instead of making mature HDL a full gyro, you got an empty pita pocket, which goes out in the urine. So those people have very low HDL. They also get a buildup of fat in their tissues and have a lot of, those two, Tangiers and fisheye, they don't walk in your office. A1 Milano does, and so does hypoalpha, but usually the hypoalphas have heart disease. So what's the question you ask if you have isolated low HDL? What's your family history? And if they have no family history of any atherosclerosis, you can do a calcium score, but they may have a syndrome where they have functional HDL, but just low steady state levels. And if they have a strong family history of premature atherosclerosis, and particularly with HDLs under 20, they likely have familial hypoalpha lipoproteinemia. Okay, so I think we talked about this. I could go through all of this and you'd shoot me because we're almost done at time. So this is just the ABCA1 transporter protein not working. So you get a nascent HDL, it's just a flat disc, no cholesterol in it, and the HDL goes out in the urine. And if you have an LCAT deficiency, you have the same problem. You have to be able to esterify cholesterol to make it go in. This red spot is not a planar xanthoma. That's the blood draw on this patient. But you see that fat thing that looks like Texas, kind of the yellow xanthoma that's flat. This is classic for hypo alpha, and it's in every board exam. They show that planar xanthoma for an ApoA1 mutation making too little HDL. A1 Milano comes from one of my favorite places, Italy. And the most interesting part of it was they went into church records and they traced it back to one family, husband and wife, Giovanni Camaroli and Rosa Giovanelli from 1780. And they were the first to have the mutation for A1 Milano, which is at 173 arginine to cysteine and on the gene. Okay, I'm going to skip this and finish. There's a lot more detail we could do, but I'm not going to torture you. The last thing I want to just talk about is, I just do it on this slide, the low LDL disorders. And there's two of them you need to know, and how do you remember them? Hypo means low levels. A beta means complete absence. Low levels is good. Complete absence, not so good. So hypo-beta lipoproteinemia is a mutation in ApoB that reduces the production of ApoB lipoproteins. These people come in with LDLs of 6 or 8, but they walk in your office healthy. And when they say, "What should I do, doctor? My LDL is really low," I tell them, get a bottle of champagne. The only caveat is that they tend to have fatty liver, and some occasionally will develop steatohepatitis and cirrhosis. So if they have elevated liver enzymes, you're going to want to refer them to GI. We're getting more and more drugs to help us with fatty liver, but that would be a rare but potentially serious problem for hypobetas. But otherwise, they do very well and they have really low risk of atherosclerosis. A beta, the complete absence of beta lipoproteins, nobody walks in your office. This is due to a microsomal triglyceride transport protein defect. They have really no ApoB containing lipoproteins. They have inability to absorb fat soluble vitamins. They have all kinds of visual, kidney, bone marrow problems, and they are very sick as children. So those people don't come to your office. That's the complete absence. So hypobeta good, A beta not good. And again, I just want to finish up. And so Lp(a) you're all familiar with. If you have questions, we can talk about it, but that's been beat to death now that we have therapies that lower it. So I'm going to stop here and take some questions since we're right at 7, at 8 your time. So hope that gives you just a little bit of an overview on a lot of stuff. I wish I had 2 hours to present that to you. And let me stop sharing.
Watch what you wish for, Alan. We may have you come back, but that was a great overview of reminding us of why patients have high triglycerides, or why they have abnormal LDL, or why they have atherosclerosis and or pancreatitis. So does anyone have any questions for Dr. Brown?
Hopefully it just gives you the so-called 30,000 foot view of lipid metabolism, and then an introduction to the many ways we can get screwed, as I say.
Well said.
So Alan, I have one question. This is Bob. Because I know that obviously, because HDL has not become much of a focus anymore, right? It's changing it, but actually HDL function or its activity is still correlated highly with vascular disease and its reversal. And there's this guy, Mike Oda, who I happen to know, PhD in sort of the San Francisco, California area, who has an assay for ApoA1 exchange, which is highly correlated with vascular disease, but he won't have a clinical assay available for at least a year. So like occasionally, it would seem like it would be useful if we had such an assay. I'm wondering, do you or anyone else know if there is an assay that's reliable?
Bob, I'm old enough to have heard this story a long time. Brian Brewer years ago had a bunch of theories on why some people with high HDL had low risk of atherosclerosis and others didn't. And he thought it was related to whether they had just ApoA1 on the surface or A1 and A2. Since that time, there have been a lot of people looking at the kinetics of HDL and its ability to get rid of cholesterol. So, and that can be looked at in a number of different ways. But the real answer is that, you know, we don't have a commercially available test yet. We, as you know, use CETP inhibitors, and they work simply by not allowing you to transfer triglycerides into HDL. So the HDL stays big and bloated with cholesterol.
Yep.
It
It
hangs
doesn't
around a long
function.
time, but very little benefit, except possibly for those ones that lower LDL. And so the right answer is, I just don't know. And so what do I do? You know, the patient says, you know, my LDL is on the high side, but I got an HDL of 110. As you know, there's a U-shaped curve now. So higher HDLs may actually increase risk, maybe not atherosclerotic risk, but they increase mortality in certain individuals, but not everybody. And one theory there is that those patients might have a mutation in their SRB1 receptor. So instead of the problem being the HDL, the problem is the HDL can't bind to the liver and offload cholesterol. I'm not sure that's correct, but if you had that, you'd have high HDL levels, but yet you couldn't deliver the cholesterol to the liver. It would remain in the circulation. So that's just one theory why somebody might have a high HDL and actually be at increased risk for atherosclerosis. But at the end of the day, whatever we've tried to raise HDL hasn't borne any fruit in terms of reducing cardiovascular risk. And I personally think it's probably very complicated because there's more to it than just moving cholesterol out of the foam cells. As you know, HDL can become pro-inflammatory in an acute situation, right? The surface proteins can be pro-oxidative. So there's a lot of things that change on the surface of HDL, and that's why I'm not totally joking when I say half of what we know is correct and we don't know which half. And in the short term, whether it's the number of HDL particles, which some people think is better predictor than levels of HDL cholesterol, whether it's the surface apoproteins or whether it's kinetics, I don't think we know really what to do with it yet. And if somebody on the call does, I'd love to hear.
Well, if I happen to find out that Mike Oda, who I've collaborated with doing research, if his assay becomes available, I'll try to let people know.
And the best thing to do is a calcium score. So when you have a question and you got some kind of screwy HDL and you're wondering, is it protective or not? And a patient wants to know, and you're not sure what to do, and they don't have clinical atherosclerosis, I personally think a calcium score is very helpful. And if it shows calcium, you can stop worrying about the HDL. If we can't hire good garbage collectors and we don't know how to hire quality collectors, we have to reduce the garbage. And that seems to work. In every setting, lowering LDL seems to work. So that's how I handle it. I just assess the risk with a calcium score. Any other questions?
Alan, just one question. A few years ago, I asked you this question about lowering the LDL significantly, perhaps into the 40s or 30s. And your answer was, is not a problem in high-risk patients if their ApoB is okay. Has there been anything more recent on that point to do it or not do it?
Well, so in all the clinical trials, lowering LDL to really low levels seems to be correlated with longevity. The only thing that's shown up recently, again, it's shown up a few times, is when you look at populations who are not on treatment with very low LDLs, you see a little higher intracranial hemorrhage, hemorrhagic strokes. But we haven't ever seen that in any clinical trials. So again, observational studies years ago showed that if you had a very low LDL, you had a higher risk of death. It was due to cancer or other things. And now we think that the reason we might have seen that was because those people were depressed, suicidal, malnourished. And so their cholesterol was low because of something else, and it may well be that there are other confounders in patients that are having the hemorrhagic strokes. But it's encouraging to see not only in the statin trials, but now that there's a open label extension on the PCSK9 trial, so we're starting to see out 5, 6, 7 years that the people with the really low LDLs aren't having a problem. So I said 30 years ago that you can't be skinny enough, you can't be rich enough, and your LDL can't be low enough. And so far, nobody's proven me wrong in the last 30 years.
Okay, and no problem with fatty liver, for example, if you get it down too low?
No, actually, that most of the lipid lowering will reduce fatty liver, but the only time that you get fatty liver from low cholesterol is when you have a problem releasing the cholesterol from the liver. So if you have a disease like hypobeta, where you just can't make the particles, that fat remains in the liver. And I think, other than that, and if you give certain drugs like the drugs for homozygous FH, lamidopide, et cetera, you're reducing the liver's ability to make ApoB particles, and that's why you're getting fatty liver. But the other causes are going to be insulin resistance and overproduction of fatty acids. And as you know, the number one treatment for that is weight loss. And number two treatment would be some of the newer drugs that are coming out.
Okay.
Alan, great talk, and always making a complex subject come easier to understand. I want to pick your brain. I've seen a handful of patients, and we know that cytosterolemia, at least homozygous, is a recessive disorder. But I've had a handful of patients who are heterozygous and have presented really with severe hypercholesterolemia, in the range of LDLs of 300 to 400, because they switched to a keto diet. I'm wondering if you've seen that, and what do you think the mechanism is? Is it incomplete penetrance? Is there still some lack of ability to be able to absorb when you're exposed to these high keto diets?
That's a really interesting question. I can't say that I've seen that. I have seen patients with keto diets get cholesterols that look like FH. I haven't tested them all for phytosterols or for G5, G8 mutations, and maybe I should. I've read that certain ApoB mutations can predispose people who otherwise would have pretty good lipids. And if you feed them a really high fat diet, they get these 300-400 cholesterols. I've had several of those, and they get referred to me because their lipids were normal 2 years ago, and now they're 400, and I find out that they're on a keto diet. So I'm trying to think mechanistically. Remember, the problem with G5, G8 mutations is you can't get plant sterols out. So you incorporate those into lipid particles. So that could theoretically look like you're seeing very high LDL levels, when really what you're seeing is phytosterols inside lipid particles. But if something's been published on that, I'm unaware of it. So you probably taught me something about heterozygous.
A while back, I remember Ernie Schaefer had presented an abstract on this, looking at that, and again showed that higher LDLs, in patients who were heterozygous when he tested for that. And
particularly if they were on a high fat diet, on a keto diet.
I don't know about a high fat diet, and I haven't seen anything published on it either. But this was a young man, in his 20s, no family history, had LDLs that had fluctuated on off for the years, and he was kind of thin and was trying to bulk up in order to go to college, and his LDL cholesterol, was well over 300, and just with lifestyle dropped it down to less than 100. So it's interesting.
That is very interesting. I have to think about that, because some of the times when we eat plant stanols and sterols, we're competitively inhibiting the cholesterol absorption.
Right.
I tend to go with plant stanols because I don't want patients to potentially absorb the sterols, but that's kind of naive. But that leads to low cholesterol. So if you were to open up the floodgates or not be able to pump the plant sterols out, the only thing I can think of is that would be incorporated into lipid particles, but I haven't seen it in the heterozygous format. So thank you for that. I'll read a little bit more about it.
So one last question for Dr. Brown. Does anyone have one? Otherwise, we have one in the chat box. Okay. All right, Alan. So someone asked the question, if patient has CAD, elevated LPA, let me phrase it correctly. Why don't the guidelines recommend PCSK9 or siRNA for treatment of the LPA? And if they currently don't, why even test for LP(a)? And I'll let that be your final question.
Okay. There's not a short answer to that. The short answer of why anything's not in the guidelines is that they are purists. And if you hear music behind you, but you don't turn around and look at the speakers, you can't make an assumption that there are speakers there according to the guideline authors. You have to prove it with a prospective randomized trial. So a little bit about PCSK9 inhibitors and LP(a). We know that it can lower LP(a), 20% or so. But we haven't done a trial that was designed to show that lowering of LP(a) translated into better outcomes. And the guidelines, they're always going to want a study that was designed to answer a specific question. So if you're going to ask a question, does the LP(a) lowering by PCSK9 inhibitors translate into better outcomes? You need to design a prospective randomized trial to study that. That hasn't been done. With that said, though, a couple of things look pretty clear observationally without a prospective randomized trial. And that is that if you have high LP(a) and you're put on a PCSK9 inhibitor, you're at higher risk, so you get a better risk reduction. And that's Brown's law number 5. Anything that works always works best in people at the highest risk. If you have a drug that reduces breast cancer death in men and women by 50%, where will you save more lives? You're going to save more lives where there's a higher prevalence of disease, which is going to be in women, right? So if LP(a) increases the number of events and you've got a drug that lowers events, those people are going to get more benefit. So that seems to be very clear that LP(a) elevation in the FOURIER and in the Odyssey outcomes predicted higher risk and also more benefit. Now, both groups did a very complicated mathematical analysis to see what happened in those people who got an LP(a) lowering versus those who didn't. And keep in mind, not everybody's LP(a) comes down with a PCSK9 inhibitor. Sometimes it goes up, even with a remarkable drop in LDL. So it's not always predictable in an individual, the LP(a) will go down. But it looks like, analyzing that data retrospectively, that the people who got an additional LP(a) lowering as well as LDL lowering got better outcomes. So we're going to know that shortly with the Horizon trial, using a drug that lowers LP(a) 80%, and we'll have better idea what to do. So why measure it? Well, number one, that identifies a high-risk individual that you should be treating all of their risk factors more aggressively. And number two, though, we don't have great data. I'll be honest. We got just 3 very small studies that suggested that if you get the LDL more aggressively lower, you're going to reduce risk in people with high LP(a). That data set is not very strong, I might add, even though we all say that with conviction. But what we're trying to do is get LDL much lower in those people. But literally within 2 years, we're going to see if targeting LP(a) reduces risk. So I think that alone is a good reason to get it. Secondly, it's an autosomal dominant trait. So if you see a family that has a lot of heart disease, you should definitely draw it. And then you want to screen the kids. And you're going to, I think you're going to find, what I've found is there's probably a lot more we need to know about LP(a). Some people have moderate elevations and no heart disease, 0 calcium scores. And you get a lot of 25-year-olds coming in because their grandfather had a heart attack and their LP(a) is 70. What do you do, And you give them a choice because you don't know what to do. We can do a calcium score when you're over 30 and we can check it every 5 years or so, or we can start you on a statin. And if you have side effects, our threshold's going to be low. But this is just clinical judgment because we really don't know what to do until we see if it should be a target of therapy. But in those families where it's 500 or 600 and these people are having recurrent events, you would want to jump all over it. And what you would do there is try to get a PCSK9 inhibitor, though a lot of insurance won't cover it, get their LDL very low, and then follow them aggressively.
All right. Well, Alan, you set the bar very high. Thank you for starting our Neela nights. Thank you for staying overtime with us.